We get to spend some time this morning talking a bit about the way that we start patients on buprenorphine, because as Dr. Voltarelli referred to, this is a really important part of um, allowing patients to access this important therapy. So our central question for today is going to be, what strategies and information can we offer to our patients who might feel reluctant to make the transition to buprenorphine? I think all of us who are healthcare providers likely care for at least some patients who have a form of dependence on opioid medications, as we've heard throughout the morning already. It's an incredibly common issue. And for some of our patients, they might take opioids for chronic pain indications, whereas we have other patients who might use non-prescribed opiates. But oftentimes with any of these patients, when we bring up buprenorphine, we'll hear a lot of hesitance from folks around the idea of making a transition. And so today's presentation is geared toward kind of helping meet our patients where they are and helping to address some of those concerns by providing information and strategies to help optimize the chances of a successful transition. So we're going to think about the pharmacology of buprenorphine. We're going to talk about the principles behind a new induction strategy called microdosing, which some of you may be very familiar with, and others, this might be new to you. And then we're going to think about specific strategies for implementing microdosing in our outpatient practice. So Lisa, Dr. Voltarelli talked a little bit about this, but just to go a little bit more in depth about why buprenorphine is so central in the conversations around opioid use disorder right now. So its first attribute is this safety profile. So unlike all of our other opiates, which are classified as Schedule II medications by the DEA, buprenorphine is a Schedule III, largely because when we do trials putting it head to head with other opioids, as you increase the dose, there is an increasing risk of respiratory depression and unfortunately death. With buprenorphine, we observe more of a ceiling effect. So after a certain dose of buprenorphine, there's not a proportional increase in respiratory depression, which leads us to believe that it is safer, and that's borne out in the data. Another fun safety profile thing is that it has some metabolic characteristics which make it safer for use in older adults. It's a little bit less subject to those age-dependent metabolic changes that we see for other medications. Bupe also has fewer of the side effects that we commonly associate with opiates. The two that I'll focus on are the GI side effect of constipation, and then the side effect of dysphoria that's really common with opiate use and dependence. So those are definitely pros when it comes to making a switch from any other opiate over to Bupe. And then a really big piece of the why we love Bupe puzzle is that there is really solid data that it provides equivalent analgesia to many of our comparable agents. So this trial listed below is a meta-analysis of 24 different trials. Many of them are RCTs that put buprenorphine head to head with drugs like intravenous morphine, specifically in the perioperative setting, and showed that Bupe resulted in equivalent analgesia to all of those agents. So that's really cool for us. And then there's some question around this last one, but there is a thought that buprenorphine at least has a slower rate of development of hyperalgesia than other opiates. So even if it doesn't reverse it, it does have less of that effect. So how can we explain all of these attributes with pharmacology? Something that as PCPs, I don't think we think a lot about, but I think can often be a really important tool in empowering our patients. And specifically helping to kind of address some common misconceptions about medications like Bupe. So let's go back to med school a little bit. And I think many of us are familiar with the fact that buprenorphine is a partial agonist. This is kind of the one fact that most people know about Bupe, and it is unfortunately the root of a lot of misconceptions. So when we think about what being an agonist means, fundamentally, a molecule binds to a receptor and it triggers a downstream cascade of a lot of different effects. A full agonist would trigger all of the possible effects. A partial agonist only triggers part of the effects. And with opioids, there's 4 receptors that I'll talk about today, probably many more, but four identified in the literature that mediate a lot of the effects that we see, some positive, some negative. So the most well-known is the mu receptor. And this is kind of the primary analgesia receptor that opioids bind to. This is where buprenorphine is a partial agonist. And the partial agonism here does mean less of a downstream cascade, but there's some thought that this downstream cascade is not the pieces that bupe doesn't do are not the analgesia pieces. It's actually some of the side effect pieces. So while it's a partial agonist at the mu receptor, that doesn't necessarily mean decreased efficacy. And we'll talk about that a bit more in a minute. There's also another receptor that's a little less well understood called ORL1 or opioid receptor like 1, terrible name, that is thought to be implicated in specifically spinal analgesia. And buprenorphine is a full agonist here. So it has really good efficacy at that receptor. And then there's 2 receptors that are implicated in the negative, quote unquote, negative side effects of buprenorphine. Most prominently the kappa receptor, but also the delta receptor. And interestingly, buprenorphine is an antagonist here, and that's some of the reason why we don't see the same level of side effects as with other opioids. So that's specifically relating to GI side effects and some of the dysphoria. So I think, while we definitely don't have to explain all of this jargon to our patients, it is a good reminder to us as providers that we shouldn't conflate different pharmacologic principles. So affinity for the receptor is how tightly a molecule binds, and we'll talk about what that means for buprenorphine next. That's not the same thing as agonism, which is the set of effects that a receptor binding relationship produces. And none of those kind of equate to efficacy. So even though bupe is a partial agonist at the mu receptor, it is essentially 25 to 100 times more potent than morphine in a lot of its effects. And so we can't conflate one with the other. So just a good reminder for all of us. So going back to that affinity piece, this is another important principle when it comes to how we understand buprenorphine and how it interacts with our patients' other medications. So affinity is going to be how tightly a molecule binds to the receptor, and a lower affinity constant means tighter binding. And so you'll see here on this chart that bupe, when we compare it with all of the other commonly prescribed opiates that we usually encounter, has the highest affinity for the opiate receptor of any. And so this is really important when it comes to thinking about how we make a transition for our patients from one opiate to another. So Lisa alluded to this a little bit, but we'll dive in a little bit more to how we have traditionally navigated this problem. So if you picture a patient who has some opiate on board, let's say they have hydrocodone on board, and you were to introduce a lot of buprenorphine to that patient's system, that buprenorphine would displace all of the hydrocodone and immediately trigger a very unpleasant sensation, which is called by the name of precipitated withdrawal. All of the withdrawal symptoms happen right away. Patient feels terrible. And so the way that providers so far have navigated this is by asking patients to wait until their pre-existing opioid has naturally dissociated from the receptor before introducing buprenorphine to the system. So that's our classic induction paradigm. We essentially ask patients to let their bodies go into withdrawal before we introduce the bupe, so that we can avoid this unpleasant sensation of precipitated withdrawal. Now, there's obviously some problems with this. One is that it's not very patient-centered. It's really distressing to patients to think about having to plan to go into withdrawal. I have personally had many patients that expressed to me that that's a big barrier for them. The other issue is that there are many of our patients that don't just take a single opioid. As we've heard about in some of the policy talks already, many of the non-prescribed opioids that are circulating have multiple different agents mixed together. They might be laced with something. And so it's difficult to predict the half-life or the time to withdrawal. And then you can see in the chart on the right that there's a huge variety in the different half-lives of the agents that we commonly see. Just to highlight one specific, methadone has an incredibly long half-life, and that long half-life has also been a traditional barrier to making a switch for patients who might desire to change from methadone to buprenorphine. Another one to highlight is just the fact that fentanyl is a bit notorious for having a very unpredictable half-life. While on paper, its half-life is about 3 to 4 hours, it is lipophilic, and so it tends to be released into the bloodstream at very unpredictable levels. And this can lead to a lot of other problems for our patients. So this piece is from a really cool publication called Filter Magazine that is meant to kind of be an advocate for decreasing stigma and policy changes around substance use. This is written by an author who has personal experience with a lot of this, who had been using opioids that were not prescribed to them, went into the expected withdrawal prior to their buprenorphine transition, and then still on top of the expected withdrawal experience precipitated withdrawal when starting buprenorphine because of the fentanyl still in their system. And this author points out that, interestingly, many folks who use substances have kind of intuitively come across a solution to this problem, which is to just use very small doses of buprenorphine alongside their other opiates to stave off withdrawal symptoms if they were, for example, not able to obtain their next dose in time. So that is kind of the story that we are working with and moving toward as a new way of starting buprenorphine for our patients. And this is a paradigm called microdosing that has been introduced primarily over the last 5 years. So it's still a pretty new field. Most of our data around it is from case studies. There are a few randomized controlled trials in process, but we'll spend a little bit of time just thinking about what's already here and ways that we can start using it, even though there's not a huge base in the literature quite yet. So true to the theme that advances in substance use happen outside the US first and then trickle down to us. The first protocol that was using the paradigm of microdosing came out of Bern, Switzerland. So it's called the Bernese Method. And so this is a kind of an illustrated graph of the protocol that was used in some of the first case reports. So the top dotted line is a patient's, what we'll call the full agonist. So whatever pre-existing opioid that is not buprenorphine, not a partial agonist, that's the dotted line on top. Then the dashed line is going to be the buprenorphine dose. And the solid line at the bottom there is the SOWS score, which is kind of equivalent to our COWS score. It's a way of denoting withdrawal symptoms. So the model here is by continuing a patient on their full agonist dose without significant change for many days. You can see that the bottom axis there goes up to 30 days. So for weeks at a time, while just very, very gradually introducing tiny doses of buprenorphine, we can get buprenorphine slowly built up in a patient's system without having that rapid displacement that causes the precipitated withdrawal. And at a certain inflection point, patients find that they don't need their full agonist opioid anymore, and they can transition directly to full buprenorphine. So I think the important principles here are, you can see that the top line of that full agonist dose is a little bit wavy, meaning that there are some adjustments to be made in the full agonist dose throughout this induction process. And also that there is, like we talked about, that kind of concrete inflection point where we can make a swap. The issue with the Bernese protocol is that it's modeled after 0.2 milligram dose increments, which we don't have access to in the US. So we had to start to rethink that to implement it here in the States. So kind of the next move that was made is to start thinking about how we could microdose patients in the inpatient setting. That's like an ideal way to try out this strategy. We have someone in a controlled environment. We can really make sure that they are gradually building up their dose. And the other advantage of doing this in the inpatient setting is that you can do it pretty rapidly. This protocol is from a randomized controlled trial that is in progress. And the way that these authors navigated this transition is that they took whatever full agonist a patient was on prior to admission to the hospital, converted all of those morphine equivalents into hydromorphone. So they're only working with one opiate. They know the half-life, it's a little more predictable. And then they rapidly introduced buprenorphine. As you can see, they started with 0.5 milligrams and dosed it every 3 hours, which is quite different than the Bernese protocol, which was done over 30 days. But even with that rapid introduction, they were able to accomplish, or they hope to be able to accomplish, let's say, since they haven't fully published their results, the same effect where they can use the full agonist opioid and actually titrate that. So even add some extra hydromorphone on top to mitigate withdrawal effects while up titrating the buprenorphine. And in this protocol, the authors hope to be able to discontinue the full agonist opioid by day 3. So much quicker than the 30 days that we saw earlier. That said, this kind of rapid titration Q1 to 3 PRN dosing of hydromorphone not feasible in our inpatient setting. So how do we accomplish this in our clinics? So this is a protocol from a Journal of the American Board of Family Medicine case series that is really similar to a lot of the others floating around in the literature. There's a very similar one from the Canadian Medical Association Journal. And the model here is that we're going to try to accomplish getting someone up to their full maintenance dose of buprenorphine over approximately 7 days, and still holding with that principle of continuing the full agonist opioid the entire time while gradually increasing. And this, as we pointed out, uses doses that are accessible to us. So 0.5 milligram dose can easily be made by cutting a 2 milligram film into quarters, and starts with just one dose and then increases to BID and then increases the dose gradually until by day 7, you're getting up to whatever maintenance capture dose a patient might need. Oops, sorry. There is some variability in the various protocols about when exactly the full agonist opioids are stopped. Some advocate for stopping completely at day 7. Others advocate for something like a 25% taper each week following reaching that maintenance dose of buprenorphine. But the takeaway is just that there are many paradigms that have been shown to be effective for patients. And so the most important piece is the underlying principle rather than the exact specifics. But how do we troubleshoot when we are working with our patients on these protocols? When we're following a patient in the outpatient setting, obviously frequent check-ins are important to help these inductions be successful. We do have some tools at our disposal. The first is, I think, somewhat counterintuitive to many of us, but as we've talked about, you can increase the dose of the full agonist opioid to help mitigate withdrawal symptoms, right? If the buprenorphine is kicking slightly too many of the full agonist molecules off the receptors, just add a few more of those full agonist molecules, you get less withdrawal symptoms. There is not good data at this point about guidelines on how to titrate the full agonist. So that's a little bit at provider discretion. The other reminder is just that we have a lot of good adjuncts that we use routinely in our standard buprenorphine inductions that can certainly be used in these inductions to help manage specific withdrawal symptoms. The blue plate on the right is a little shout out to our ARS colleagues who call this group of meds the blue plate special. But thinking about for specifically the anxiety and the hyperarousal that can come with opioid withdrawal, using agents like hydroxyzine and gabapentin. For the muscle cramping and myalgias, we can think about muscle relaxers such as tizanidine. And then of course, for the GI distress that comes along with withdrawal, thinking about agents like dicyclamine and ondansetron. There's also a very cool, thinking about other alternate delivery forms of buprenorphine. We do have even easier ways to accomplish this microdosing concept, which come in the form of a buprenorphine patch. So this is a therapy that is currently FDA approved for chronic pain, unfortunately not approved for opioid use disorder at the moment, but it's a beautiful setup in that the 20 microgram patch essentially releases about 0.5 milligrams over the first day, which as you remember is just exactly the same dose that was recommended in our microdosing protocol. So this is a potential option to slap a patch on a patient, have them keep using their endogenous opioid and auto microdose them, which is awesome. Unfortunately, it's pretty unavailable at this point in most hospital formularies and even outpatient pharmacies, and it certainly is more cost limiting than our sublingual forms of buprenorphine. But just to review kind of our key principles, our key takeaways for microdosing, at this point, again, there's no particular set strategy, so we get to navigate this through our discretion as providers based on our relationships with patients. So key takeaways are just to remember that we can help our patients better understand the benefits of buprenorphine for their particular situation by understanding the pharmacology well ourselves as providers and relaying that to our patients. As I mentioned, there is not at this point a right way to microdose. And so feel free to reference some of those case studies as you navigate this with your own patients. I think that as you may have gathered, flexibility is key here. There is a lot of wiggle room for missing a day, delaying titration by a day, whatever patients need, we can accommodate here. And then remember that the troubleshooting principles are to titrate that full agonist opioid and use those adjunctive symptom management strategies. And finally, I think that this strategy appeals to me, and I think many other providers, because it really does build on that therapeutic alliance we have with our patients and allow us to help them make this transition in a way that centers their needs more than our kind of nervousness as providers. So hopefully this is something you can try out in your practice. I'm happy to take questions, and here is my slide for references. Make up that lost time. Yeah. Yeah, that's great. Yeah, the question that was brought up was about, oh, well, we have one first that's please clarify induction protocol for Suboxone currently without microdosing. So just to review that, typically the way that we use our induced Suboxone right now is, or buprenorphine, naloxone to use the generics, is to ask patients to abstain from all opioids until they feel withdrawal symptoms, to come into clinic or to do a phone visit at the time of withdrawal symptoms, and then to begin a dose of buprenorphine, either observe them in clinic or check in with them by phone several hours later, assess for withdrawal symptoms. If withdrawal symptoms are present, to increase that dose, and then to check in again, typically the same day, depending on your level of suspicion. There are some calculators that allow you to get a sense of kind of the estimated need for buprenorphine based on a patient's prior dosage of opioid used. And then once you have your day one dose, you're going to have a second phone visit the next day to check in with the patient, again, assess for withdrawal symptoms, again, titrate the dose to symptoms as needed. As Dr. Voltarelli mentioned, typically our target dose for most folks is maxed out around 16, though you can certainly go to 24 if really needed. And so that allows us to identify essentially the quote unquote capture dose, or the dose that allows patients to go forward without withdrawal symptoms. Typically start with 4 milligram titrations, but it does again depend on kind of how much buprenorphine you expect the patient to need based on their pre-existing morphine equivalents. And then
the next question,
yeah,
how do you feel about moving away from language like induction to medication start to make it less intimidating to providers?
So the question is about kind of clarifying our language around buprenorphine inductions and changing from talking about inductions to starting medications. And I love that paradigm. I think anything we can do to make this feel less intimidating, both to us as providers and to our patients, is great. So thanks for that question, Dr. Martin. And then the other question that was brought up was just the previous question about accomplishing these inductions in clinic setups where we don't have as much nursing support or don't have nurses trained to do this. And I think as residents, we manage all of our own inductions without that support. And the way that we navigate it is just to leverage a lot of the telehealth tools we have available to us. So I personally do a lot of phone visits when I'm inducing someone on buprenorphine, or virtual visits, because it is something that lends itself well to telehealth. But I don't know if other providers want to chime in with other suggestions. Typically having phone visits at least on the day after induction, and then a few days later to check in with a patient and make sure that, again, we have helped them minimize their withdrawal symptoms so that we have the greatest chance at retention.
Let's see, how do you calculate dosing? Do people typically know how many milligrams of fentanyl, et cetera, they are on?
So there's a question about how do you calculate bup dosing, and do people typically know how many milligrams of fentanyl they are on?
And
I think
also, is there a resource you can recommend for estimating?
Good question. Yes, I certainly can try to find that for you. I don't have it off the top of my head. If anyone in the audience has their favorite, we can pass it along. If not, we can put it in the chat later if you're able to view the chat. Typically, most patients do have some sense of the amounts that they're using. Not universal. There are some ways to grossly estimate in terms of like cost that patients are spending on their substance of choice and how that converts to milligrams.